Welcome. The American Association of Neurological Surgeons is accredited by the Accreditation Council for Continuing Medical Education to provide continuing medical education for physicians. The AANS designates this live activity for a maximum of one AMA PRA Category 1 credit. As a provider accredited by the Accreditation Council for Continuing Medical Education, the AANS must ensure balance, independence, objectivity, and scientific rigor in all its sponsored educational activities. In accordance with the ACCME standards for integrity and independence in accredited education, the AANS is required to disclose to the activity audience the relevant financial relationships of the planners, faculty, and any other individual in a position to control content for this activity. Those who have disclosed a relationship with ineligible companies are listed on the current slide. All disclosed financial relationships have been mitigated in accordance with ACCME standards. Planners, faculty, and any other individuals in control of content not listed have indicated that they have no relevant financial relationships or conflicts of interest to disclose for this activity. Credit claiming will be available in our learning management system, NeuroU. Claiming instructions are on the screen and will be shared again at the conclusion of this webinar. By the end of the week, participants will receive an email notification of enrollment to claim credit. This notification email will also include the instructions on screen for your convenience. For any issues or questions regarding claiming credit, please contact education@aans.org. Now, to get us started, I'd like to introduce Dr. Chakravarthy.
Thanks, Tim, for the kind introduction and some of the opening comments. So welcome, everybody, to the AANS CNS tumor section. This is a part of the Spine Oncology lecture series. I believe it's the third of total of 5. Today's topic is going to be on radiation oncology for the practicing spine surgeon. The goal of this webinar is to cover the basic spine radiation, its indications, how it fits into the paradigm for treating both primary and metastatic tumors, and the discussion will be geared towards surgeons and the practical aspects of radiation that they should understand for day-to-day patient management strategies. We're hosting actually 2 radiation oncology experts today to kind of to lead both aspects of this discussion. The first will be Joshua Palmer. He's a full professor of radiation oncology at Ohio State University and the director of the CNS Adult and Pediatric Radiation Oncology Program. He specializes in the treatment of tumors of the spine and CNS with multiple active clinical trials. That'll be followed up by Dr. Arpit Chabra. Dr. Chabra is an attending radiation oncologist at the New York Proton Center and an assistant clinical professor in the Department of Radiation Oncology at Mount Sinai Health System. He specializes in the treatment of CNS tumors as well as spine tumors and other malignancies. We'll start with Dr. Palmer to kick things off. For any attendees, if you guys have questions, please feel free to put it in the chat. If they're relevant to the presenters' talks, we'll deal with it through the talks. Otherwise, we'll hold them until the very end. Thanks, and thanks for attending.
Thanks, everybody, and thanks for the kind introduction. It's wonderful to be here to talk to the neurosurgical community about spine radiation treatment. We'll jump right in. So these are my disclosures. So the goals of therapy are to alleviate pain, prevent or reverse neurologic dysfunction, and prevent local progression of disease when we're thinking of spine oncology patients. It does take a team to do this, so we typically put the patient at the center, discussing the case with neurosurgical orthopedic spine surgeons, the neurologists, radiologists, and medical oncologists to make these decisions, typically in a tumor board setting, especially when it comes to offering a patient surgery followed by radiation therapy. Typically follow some form of decision-making tree. The commonly used are the MNOP or the NOMS criteria. We'll go through the NOMS criteria briefly, what we look at as a radiation oncologist to make these assessments and how it fits in with the spine neurosurgeon. The neurologic assessment is typically looking at the Bilski grading of epidural disease. And typically when we're looking at these, 0 to 1B can be treated with radiation alone. So external beam or radiosurgery based on histology typically. 1C, it's unclear, can benefit from surgical decompression. Some do get radiation alone. And then high grade cord compression, group Bilski's 2 and 3, typically are offered in many settings unless other parts of the NOMS criteria prevented, surgical decompression, stabilization, followed by radiation therapy. The oncologic assessment is typically our ability to look at the tumor's response and durability of response. Radiation-sensitive tumors like leukemias, lymphomas, blood-based tumors, some small cell tumors, and germ cell tumors, typically we offer radiation alone or chemotherapy alone in some settings. Radio-resistant histologies like melanoma, renal cell cancers, lung, thyroid, most GI primary tumors and sarcomas typically are thought of as resistant and get offered radiosurgery up front, even for low epidural grade disease. Mechanical stability, this is where the surgeons and the radiologists are quite helpful. We use the SINS criteria to look at stable, indeterminate, and unstable, the unstable patients typically being offered surgery. Systemic disease, typically we're looking at this with the medical oncology teams. You can use things like the Sorg nomogram. There are many other sort of validated measures you can use for an estimation of survival. But if the patients have a predicted survival typically over 3 months, then getting aggressive with surgery and radiation treatment is appropriate. We typically will look at the NOMS criteria for those individuals that could go straight to radiosurgery or separation followed by surgery. This was typically thought of as a radiation alone disease many years ago. We would give radiation for patients that came in with spinal cord compression or epidural disease. Conventional radiation therapy was the standard when this trial was run. And the study was looking at the addition of surgery. Is there some benefit to these patients for control and ambulation? And what they found was adding surgery to these patients' care did significantly increase the amount of ambulatory patients and control of disease. External beam radiation, which was the historical standard and still is offered for many patients in the community setting, is a either 2D or three-dimensional treatment. It's simple planning that takes usually a few hours to do. Same-day starts can be done, so simulations in the morning and treatments in the afternoon. Good for emergencies or things over the weekend or things in after-hours settings. You do increase the high dose to the normal tissue. As you can see, the red dose does go through the abdominal compartment, so the area of disease as well as normal tissue gets similar dosing. You can get hot spots as well in normal tissue more prevalently with an APPA or three-dimensional technique. We usually are doing these in 1 up to 5 and 10 fractions are the most common fractionation schedules. And then looking at the radiosurgery technique, you can see a much more conformal radiation design. So these are give us the ability to create donut shapes. So this is coring out the center of the canal so that we're sparing the spinal cord, but also treating all of the involved vertebral segments and can be done in multiple vertebral body levels. It's good for radio-resistant histologies because the dose can be escalated to a more ablative killing dose. It's a good option for retreatments when you're trying to lower the dose to organs at risk that are nearby. Setups are really critical, so we typically don't require much immobilization for an emergent setting patient, but in a patient that's getting radiosurgery, we need to be able to immobilize the patients with knee and foot sponges as well as stereotactic body frames and vacuum bags to be able to align the patient and reposition the patient properly. We also use tattoos for alignment and CAT scans during treatment. We use masks for patients in the upper cervical, the cervical spine and upper thoracic spine. High resolution imaging is required, so we use the MRIs and CAT scans for treatment planning. Historically, when titanium is used, titanium cage or titanium hardware, we use CT myelograms to delineate the thecal sac and spinal cord because it's very difficult to see. You can see in the bottom 2 left panels that a T2 and T1C, you can actually not easily identify the organs at risk for the spinal cord or nerve roots, but you can see those on the myelogram quite well. The majority of the patients postoperatively with titanium do tend to get CT myelograms still in practice if titanium is used. We do that because in the postoperative setting, MRIs can overestimate the spinal cord. So in settings without myelograms, there have been multiple studies that have looked at contouring the spinal cord, both with and without an additional myelogram. And what you can see is there is some inconsistent drawing of the spinal cord, allowing for a potential increase in the dose of the true cord by up to 1.2 gray, which when we're trying to push some patients to a dose that is ablative, this can potentially lead to a spinal cord injury. CT myelograms may not be necessary in settings where you use carbon fiber hardware. If the carbon fiber is used in the screw because and typically the screw or the cross attachments or cages because you can actually delineate the spinal canal quite well. The thecal sac as well as cauda equina spinal cord can be seen much easier. You can also do perfusion imaging in these settings. And so when we looked at our patients getting carbon fiber, initially we were doing myelograms along with the MRIs, and we saw that there was no distortion of the spinal canal, leading to us contouring and having a significant overlap of the MRI contoured, CT contoured cord. So we have, in routine cases, stopped ordering CT myelograms for that reason. There are situations, though, when you get the postoperative MRI where they may still require the additional clarity of a CT myelogram. This was a patient that had quite a bit of reconstruction as well as a lot of additional sort of tulip head artifact. There's a lot of vertebroplasty cement augmentation at multiple levels. And so because of a number of different patient factors, we still could not identify on the MRI the canal, so it still required a myelogram. So it's not every patient, but can get you away with the majority of patients. Should we cover the entire vertebral body? This was a debate back when we started using radiosurgery. What they found was there's a much higher risk of tumor failure if you don't only treat the tumor alone with a margin and not the entire clinical target volume, which includes all the Boreani segments, essentially, of what would be removed with surgery. Deviation from these consensus guidelines tends to increase the risk of failure. So what you're seeing here is that there's a tumor that recurred here, or a tumor that was involved here that recurred there, but was not treated in the radiation treatment, but should have been because of the tumor involvement of the vertebral body. Typically, that adjacent segment should have been in the volume initially. And so we do see a 2.5-fold increase for those that don't follow these SBRT guidelines that have been published. These are the original Cox guidelines from 2012 that do sort of follow a similar clock face, sort of Boreani-like um, treatment algorithm. This is sort of a similar post-operative version, also published more recently by Dr. Redman from Johns Hopkins, looking at the segments that are involved for those segments that should be included in the CTV. We do look at critical structures. We have volumes for 1, 3, and 5 fraction, as well as 2 fraction radiosurgery for individuals choosing different fractionation regimens based on your institution. We have dose constraints for the spinal cord and caudate quina as listed here. We do know that if you delay the radiation treatment or have delays based on post-surgical healing and wound infections or other complications, we see that local control goes down significantly if it's delayed over 40 days. So we do ideally want to try to minimize or do minimally invasive techniques, trying to get these patients onto treatment as quickly as possible. We did also see in this initial experience that preoperative embolization did improve local control, which we're testing in a prospective study. You can see we looked at this in more detail. The more complete an embolization was, it did predict for higher control. And we did see that the addition of embolization to surgery and radiosurgery did seem to impact in the total cohort local tumor control. And this wasn't just renal cell tumors, it was sort of a smattering of additional histologies. Dose and fractionation regimens do differ depending on institution, but we typically see somewhere between 16 and 24 gray in a single fraction, 24 to 28 in 2 fractions, 27 to 30 in 3 fractions, and 30 and 35 gray in 5 fractions is the common ones. We do know that the higher the dose equivalent, so as you get higher to 24 and 1 or 30 and 3, we do see a dose response. So the higher the dose seems to have a higher rate of control. Treatment delivery is critical. There's a lot of different mechanisms to do treatment. So these are just several that are listed here. We're typically doing some sort of highly conformal technique like VMAT or IMRT, doing multiple beams or arcs to get the treatment to be conformal in the area of interest. But differences or shifts in not being accurate can be critical. So image guidance is incredibly important. These robotic couches that allow us to correct for 6 degrees of freedom are important, and on-beam imaging is important. Image guidance daily can be the difference between an injury or a miss, because you can see here, this is the dose fall-off of a typical treatment plan, that over a period of about 3 to 5 millimeters, you're going from 100% to 40% of the dose of radiation treatment. So improvements in this accuracy are important. We've created something called IMR tracking and monitoring. IMR tracking is essentially turning on the beam during treatment or using exact track like images in monitoring the skeletal hardware. You can see that majority of treatments are within tolerance, but there are several fractions throughout people's courses that may go out of tolerance, and those individuals need to be re-imaged, realigned, and continue with their treatment. So you can see that the average translational motion was only 0.3 millimeters, but we do set a limit of about a millimeter to try to keep within tolerance of our organs at risk. And there are some patients that do go outside of that tolerance, which can lead to upwards of 2 gray increase in the critical organ, like a cord dose, which could theoretically lead to cord injury. So we do recommend some form of either on-beam imaging with multiple cone beams throughout treatment, x-rays throughout treatment, or like we do sort of a tracking during therapy itself. We're not particularly good at monitoring this with our visual, like looking at it with multiple people passively. So we can see that here the red is how inaccurate we are when patients actually moved out of tolerance. The inability for us to do this without some sort of active management. So we've come up with IMR tracking, which is an active tracking system which monitors fiducial markers, which is seen here. That would allow us to essentially lock on to those sort of fiducials placed at the time of surgery. So that way we can actually see these moving throughout therapy. And if they get red or out of tolerance, we can then move on, get a CAT scan, reset them up, and then continue with the treatment. We do think that potentially radiation technique impacts fusion rates. There's still many that fail in a metastatic setting with these patients. Some may never fuse, but there are patients that do if they live long enough. We see in this Mayo Clinic experience that when you use radiosurgery as opposed to the historical standard, which was conventional treatment, which used to treat more of the hardware in areas that would potentially lead to non-fusion or non-union, we see that the patients that got radiosurgery had a twofold increase in fusion rates at 6 months and durable through a year, up to 80% of patients that got radiosurgery. So we do hope that by getting more conformal, potentially using things during surgery to increase the rate. There's some people using different medications during surgery, or like placements of sort of union medications, implants to help with that for bone growth, but still yet to see that done in a prospective way. Outcomes are excellent. So with radiosurgery to intact bone tumors, we see a very high symptom relief, up to about 90%, with local control up to about 87 to 90%. We have randomized evidence in phase 3 studies showing that patients with 1 to 3, mostly 1 to 3 lesions in a SINS intermediate or less cohort, mostly breast and GU, that if you give radiosurgery, these patients have a significantly better pain response. So both at 1 month, 3 month, and 6 months. So it's a durable pain response. We see that on multivariate analysis as well, that 3 and 6 months pain improvement is significantly favoring radiosurgery over conventional treatment. We also see in this meta-analysis that we performed that there's a significant benefit to tumor control. But somehow I lost screen share. Give me 1 second. You guys still hearing me? I don't know if maybe my computer went out or something.
Still hear you.
So give me 1 sec as I set it back up. There we go. All right, hopefully it's back in there. And so what you can see is that in the patients given the radiosurgery, there was a significant benefit to local control in the meta-analysis. And we do have randomized data now in patients that have what we call oligometastasis. So this is patients that could have spine lesions, but have less than 5 total number of metastases. There was a significant benefit to overall survival. So we're starting to see in these patients, now that there's multiple clinical trials in Europe and in the United States, showing a significant benefit to radiosurgery, even in the setting of metastatic disease, both impacting pain, quality of life, and overall survival in some settings. Patterns of failure are still typically in the epidural space or paraspinal regions. And so those are critical to identify well on your postoperative scans. We do see myelopathy, but it is at low rates, typically less than 1 to 2% for the upfront treatment. Vertebral compression fracture is also a critical side effect for us to watch long term. Typically, with high dose single fraction, it tends to be higher than with fractionated treatments. We tend to quote 5 to 7% for fractionated therapies, can be up to 20 to 40% for single fraction high dose. Reducing this is important. We do see that dose and increasing the dose does increase the rate at which we see fractures long term. And we do think that things like end plate disruption in our recent paper show that these can impact patients getting fractures, so potentially identifying patients that should get kyphoplasty or surgical intervention up front, adding to this literature here. And then we also see that in the Mayo Clinic experience, epidural disease, lumbar location, tumor size, and SINs all predicted for higher rates of fracture long term. Pain flares happen up to 2 to 35%, up to 40% in some series. We typically give steroids, now boswellia, to all patients to prevent pain flare. We typically see very low rates of pain flare if they're prophylaxed. Post-SRT follow-up, this is somewhat challenging. We do see pseudoprogression after radiosurgery, so it is critical to follow these in a multidisciplinary fashion. Spinos come up with a way to categorize follow-up for these patients, typically every 3 months for that first year. And it's distinct from what we typically see from RECIST criteria because there is no complete or partial response. It's just progressing or controlled, typically. We do see any newer progressive tumor is considered progression of disease. The pseudo-progression phenomenon would fit in the stable disease. We think that perfusion can potentially aid in understanding if they're progressing. You can see as an example here, a tumor that was preoperatively preoperatively and postoperatively, but pre-radiosurgery had perfusion, and then after treatment, the perfusion goes away. This patient's now several years out with no progression. This patient is a good demonstration of a tumor that, based on RECIST criteria or based on measurements, never progressed, but you can see that perfusion started to progress sort of independent to that. We ended up taking this person back to surgery after about a year, ended up showing that this was recurrent disease after the initial course of SRS, was then given postoperative radiosurgery and has remained controlled since then. Tumor response, like you see here, is quite difficult. This is a partial response. These are patients that are having epidural progression, so that's difficult to identify with hardware, but critical for us. This is a patient with bone-only progression, so you can see that the sort of change in the bone marrow signaling. But pseudoprogression is very difficult. It usually presents with that T2 edematous bony change, but we also think adding PET scans can theoretically add to the Spino kind of criteria. We see those patients with stable to improved PETs have a much higher rate of clinical control than those patients that have less than a complete response on PET. We see that with carbon fiber instrumentation, you can identify these epidural recurrences earlier. This was a patient where we started to see after 2 years prior radiosurgery, we started to see a slow regrowth in the epidural space that we would have taken probably another 6 months to see if it was MRI with titanium. So that's what we saw in our initial experience, that we do identify these earlier in their course of treatment to hopefully be able to treat them sooner and get better control. Reirradiation is also possible. We do see that the normalized BED long-term, trying to keep that rate of radiation myelopathy low. If you keep the total BED less than 70 gray. In our experience, we see a local control even after second course of radiosurgery, up to about 90%, with a great rate of which we see grade 3 myelopathy less than 5 to 7%. So in summary, patients with spine metastasis should be managed in a multidisciplinary fashion. Having some criteria or way to think about these cases in NOMS or MNOP is important. For select patients, radiosurgery alone can offer high rates of control and symptom relief. Dose and fractionation is important because it does predict for toxicity. Lesions progressing after conventional can be treated with radiosurgery and surgery, and MRI as standard imaging right now. Adding PET scans may come in the future because challenges do exist in that post-radiosurgery pseudoprogression space. Thank you, guys.
No, thanks, Josh. That was a very, very in-depth, deep, and quite efficient coverage of a lot of material. And so there's a ton to think about. And I think we'll, for the time's sake, we'll switch over to Dr. Chopra. We'll let you give your talk, and we'll kind of hit you guys both with some questions at the end, and there'll probably be some overlap in the questions that we ask. It'd be good to kind of combine it all together. So
Yep,
without further
sounds
ado, yeah.
perfect. Thanks, Chris, and thank you guys again for the invitation to speak. We'll flip gears a little bit here. What you'll notice is, I think, as Chris mentioned, we'll open up for questions at the end, and there'll probably be some overlap. But what I wanted to talk about is the discussion around proton therapy, obviously a novel and unique form of external radiation techniques, predominantly for primary spine tumors. Make sure it scrolls through. So, as Josh mentioned, you did a phenomenal job talking about metastatic disease, in which SBRT and SRS are a very, very growing paradigm, increasing utilization from the standpoint of radiation oncologists. On the flip side, obviously primary spine tumors represent a much smaller presentation of spine oncology histologies. But that being said, as you can see here, there's sort of a variety of histologies and tissue of origins that we see, including sort of aggressiveness, grade, whether they're benign or malignant. And one of the things I want to highlight is that for the vast majority of the entities and histologies that you see here, the prognosis is obviously significantly better than those who have metastatic disease, and potentially curable, actually, for the majority of patients and majority of histologies that you're seeing here. And so I want you to kind of keep that sort of that nugget as we talk about why we would think about treating these patients with something such as proton therapy versus utilizing photon-based external radiotherapy. And so before we sort of get into patient selection and talking through histologies and the rationale, just want to introduce the concept of proton therapy, because I know there's a variety of individuals on this call who may or may not have proton centers at their respective institutions. With conventional radiotherapy, photon-based, the way that photons and X-rays work is, they travel through the entirety of the body. And the way, this is kind of an oversimplification in the picture that you're seeing here, but the way that they generally work is that there is some buildup effect after the photons sort of reach the skin surface and enter, after which they sort of exponentially decay. And with decay, you're obviously trying to get at the distance of the tumor, depending on how deep that is, 100% of what you're trying to prescribe in terms of the dose of interest. Thereby, after that, though, X-rays still continue onward, and thereby the surrounding normal tissues that are in the vicinity of, talking about spinal tumors, whether that's sort of the head and neck structures, the chest structures, the abdominal structures, do get low to moderate amounts of radiation dose. However, on the contrary, proton therapy represents sort of a unique form of external radiation in that it has a very distinct property. In the blue line here in the picture, as you can see, it too has a little bit of a buildup effect, but its predominant buildup is actually happening at the area of the tumor, because it's got a phenomenon called the Bragg peak, which is where the majority of the dose distribution occurs. It's kind of how I describe it sometimes to individuals is like a bowling ball. The bowling ball is going very quickly until it starts to slow down, and when it slows down and stops is where the concentration of dose and energy is being delivered. And we can tailor that distance by knowing what the energy of the proton particle is that we release from the machine or from the cyclotron. It has this unique property that after that sort of concentration of dose deposition occurs, it actually falls off very quickly, such that thereafter there is minimal to no exit dose. And thereby that allows you to release a lot less radiation dose to the surrounding normal tissues, opening an opportunity to minimize the risk of short and long-term side effects, one that's pertinent, as we'll talk about in subsequent slides, but also allows an opportunity to dose escalate and deliver a higher dose for certain histologies than what photon-based therapy can do, because that's limited by the constraints and the sensitivity of the surrounding normal structures. So again, in this sort of simplistic cartoon format, you can see this sort of posterior fossil tumor and where the differential between protons and photons would be and how that would occur. Again, being very simple in the sense that this is just a singular beam coming in from the left to right on the slide, but you're seeing that after reaching the point of the tumor, protons are obviously stopping, thereby minimizing dose to the anterior structures there. Whereas with photons, there is still some low to moderate dose that gets deposited. And I thought a video would certainly speak 1,000 words. And so, I want to show this video. Obviously, it's a right-sided lung tumor, but I think really nicely exemplifies how proton delivery occurs, specifically pencil beam proton therapy, which is the most modern form of protons, what's available, obviously, here in New York and obviously at OSU and other institutions. But what you'll notice here, as I set the stage, is there's going to be a distribution of colors, right? The red is the 100%, which is the dose we want to deliver to this tumor, or be a spine tumor in the respective dose. The blue, the green, the yellow is that fall off, like Josh showed. It goes from 100% to obviously ultimately 0%. And this beaming is being delivered from this point right here on the right side of the patient, and it's painting the dose at the most distal furthest edge of the tumor, because that's the highest energy protons that first get released. We thereby lower the energy of the protons from the machine, and so they can sort of have that Bragg peak effect in more shallow rings. And you're essentially just painting the entirety of the tumor to the dose that you want to give. But the biggest piece that I also want to show is that there is this lack of exit dose, the sparing of normal tissues on the other side of where that beam came in from, and obviously on the distal side of where that tumor occurs. So if you sort of imagine this occurring here in the spine, you could see how in a situation like this, there's a good amount of sparing of the heart, esophagus, lung tissues, and normal tissues that are sort of anterior and sort of surrounding the area of interest that you're trying to treat. So how do we use this phenomenon, this sort of unique property of proton therapy, when we think about who to utilize it for and who to treat? And I think one of the things I want to emphasize, is sort of noted on the first bullet point here, is proton therapy is really appropriate for a subset of patients, so not for all types of patients. Obviously, across all disease sites, there are a subset of patients that benefit from protons. When you talk specifically about spine oncology, obviously it's not commonly utilized for metastatic patients in general. And obviously that's because the use of SBRT has very high rates of local control and success and low toxicity, as Josh just sort of exemplified. But when you think about primary spine tumors, there are certain factors specifically around primary spine tumors that make protons potentially more appropriate than conventional radiotherapy. And that's given the fact that obviously these tumors are in the vicinity of a lot of surrounding structures. The cord is just one of many. Similarly, these patients sometimes are on the younger end, but they also have a long life expectancy, as we talked about in the beginning of the slides. And so there is an imperative importance to emphasize trying to widen the therapeutic ratio, trying to minimize the risk of side effects, short and long term, trying to improve local control through dose escalation means, because again, this is a patient population that has a much higher survivability than obviously those that have metastatic disease. And so for primary spine tumors, we do tend to very strongly and very commonly think about utilizing proton therapy as opposed to conventional radiotherapy. Again, this is just kind of reiterating that point that proton therapy allows us to sort of widen that ratio. For intrinsic spine tumors, obviously it allows us to sort of minimize the normal tissue dose to the surrounding structures, whereas for paraspinal tumors such as a chordoma, chondrosarcoma, those entities require significantly higher doses of therapy for local control, which again, because there is normal tissue sparing, protons allows us to do a better job than conventional radiotherapy does. And so when you sort of bucket some of the entities, and this is not fully exhaustive, but some of the entities that occur from a standpoint of primary spine tumors, I wanted to kind of exemplify some of the highlighted data, and I'll go into more depth into the subsequent slides, where the data sort of supports the utilization of protons when you think about these buckets. So when you think about primary spine tumors, again, just to reiterate, when you're thinking about sort of low to intermediate grade spinal ependymomas, or thinking about peripheral nerve sheath tumors, meningiomas, hemangiomas, things again that have high rates of local control and survivability, you're thinking about the ability to minimize the risk of side effects for those patients who you know otherwise have a high likelihood of doing well. And again, that's sort of why there's the reduction of toxicity note made above sort of this first column here. On the secondary column of chordomas and chondrosarcomas, again, these require steep dose responses, generally above 70 gray. 70 gray significantly supersedes the dose constraints and the safety of what the spinal cord can take, and obviously of what the surrounding tissues such as the bowels, the esophagus, can also tolerate. And so thereby, because protons has the ability to minimize exit dose, allows us the opportunity to be able to dose escalate and achieve the doses that we want to give these patients the best chance of local control. And lastly, to kind of, I guess, straddle the primary versus metastatic, This is a growing area within the utilization of proton therapy. So I wanted to highlight it here, which is patients who have leptomeningeal disease, who historically have had, and obviously and still do, but historically have had pretty poor survivability. It's been shown, based on a randomized trial, which I'll go into, that the utilization of protons to cover the entire craniospinal region and axis versus just sort of spot welding actually has a overall survival benefit for a patient population that otherwise, obviously has a very, very tough prognosis. And I'll show why proton specifically is a better modality to be able to deliver craniospinal radiation than conventional radiotherapy can. And we'll get into that sort of at the end of the slide. So I think some of the clinical cases that we treated in New York sort of can exemplify, again, going into each of these columns and why we thought about utilizing protons, and obviously what some of the doses and dosimetry looks like. These are, again, this is a young patient, 27 years old, who's got a WHO grade 2 spinal ependymoma, underwent a subtotal, got 52.2 gray of pencil beam proton therapy. Again, why we thought about utilizing protons for this individual is, again, because of the high rate of potential curability, obviously young age. And so in that regard, you can see that when you look at sort of the dose distribution or the rainbow between what's the 100%, the dose we want to deliver, which is 52.2 gray here in the red, the target being this internal structure here, you can see why we felt that protons was appropriate to minimize the dose to the anterior normal structures here in the head and neck region, but also laterally, when you look at it on the axial slices, to just overall minimize what we call integral dose, keeping the dose really conformal and just around the tumor of interest in an effort to minimize the risk of not only the short-term side effects that could have occurred from radiating the mucosal axis here, but also the risk of long-term side effects of over-radiating the thyroid, as well as the normal tissues and the musculature, which can have a potential for secondary malignancies in somebody who's 27 years old. And so when you look at the data, and again, this is growing data, and our paper is being sort of written right now for our experience in treating spinal ependymoma with proton therapy. But prior to that, right now there is still limited data, predominantly just on 8 patients who've been treated with WHO grade 1 and 2 ependymomas, utilizing protons in sort of a range of doses that we delivered. What you find is that local control is as you would expect it to be, very, very high. Overall survival is very, very high. And just as importantly, the toxicity is very, very low. And I think that's exactly one of the rationales for why we use protons. So we want to achieve this high and maintain this high rate of control and minimize toxicities to grade 1 or grade 2. Flipping over to entities like chordomas, which, obviously, as I mentioned, require steep doses, much higher than the 52 or 54 gray that we talked about for ependymomas, but closer to 70 plus gray. This is a 74-year-old who had a cervical chordoma that underwent neural total resection and then subsequently got treated to 74 gray of pencil beam protons. What I've exemplified here again is you're seeing obviously the area of interest that got the 74 gray, and I've dropped the dose down to exemplify where the 20 gray is, which you can see is very tightly around that area of the paraspinal and the spinal region. Whereas if you had seen a plan comparing this to photons or to conventional radiotherapy, that 20 gray would be across the entire axial slice. I mean, it'd be in the laryngeal region, it'd be in the esophageal region, it'd obviously be in sort of the muscular region. And that, again, is something we want to minimize because the larynx, the esophagus, these entities, the spinal cord cannot take 70 gray. Their general dose constraints are somewhere around 45 gray, 50 gray, sometimes pushing it to 60 gray in the esophagus, but all which are much lower than obviously the 74 gray that you're trying to achieve for the tumor here. And so you can see why protons becomes really a strong modality when you need these very, very high doses for achieving really good local control. And the same applies in the sacrum when we think about treating these patients definitively for those who, have a high risk of morbidity from a surgery, depending on the location of their sacral chordoma. This again exemplifies a patient who underwent 76 gray. And in the vicinity of the 76 gray, obviously, is significant amounts of bowel, rectum, bladder, the parasacral musculature. And what you'll see from the dosimetry is the beams are coming in posteriorly from the back, and we're exactly using the ability that protons stop and disappear with that lack of exit dose to basically be able to put the 20 gray right here while still putting 76 gray into the sacrum itself you could see the significant degree of bowel and bladder and pelvic tissue sparing, which is exactly what you want to achieve to minimize the risk of side effects, but also be able to give 76 gray, which is necessary to this patient. And so we know that, when you look at the data, and for chordomas and chondrosarcomas, obviously there's long-term data now of more than 5 years. Proton therapy, achieves significantly good degrees of local control of as high as 94%, when you are able to get the dose in that is appropriate, which again is at least 70 gray for these entities, and is safe enough to do so, and keeping the risk of myelopathy, which is obviously a side effect we think very, very strongly about, given how devastating it is, with thankfully very, very low rates of myelopathy, as seen when you look at the data, specifically for the utilization of protons, and you respect the constraints that we know are appropriate. And so in my last couple of slides, just kind of talking through that last column, again, as I mentioned, this is not primary spine tumors, but again, a very, very strong indication for using protons in the spine. So I wanted to kind of at least touch upon it, is this growing utilization of proton CSI for leptomeningeal patients. And this data was led by the MSK and the Neuroproton Center team here by Jonathan Yang, who is now at NYU, looking at patients with leptomeningeal disease with multiple solid tumor histologies who got randomized to proton CSI versus photon-involved field radiotherapy, so treating the area of just interest rather than the entire axis. And they looked at CNS progression-free survival, they looked at overall survival, they looked at side effects. And what they found is that with the utilization of proton CSI, there was a significantly higher progression-free survival because they were able to treat the entire axis. That led to an overall survival benefit, and was able to achieve that without a significant difference in grade 3 or 4 increased adverse events, in part sort of exemplifying that even when you're treating from the top of the brain down to the spine, that because there's that lack of exit doses, I'll show you, and you can spare the surrounding normal tissues from really getting minimal to absolutely no more dose, patients can actually tolerate and complete this treatment. And that's one of the discussions that's currently ongoing, as this has led into now a phase 3 NRG-sponsored trial, is the difficulty of doing CSI with VMAT or volumetric or conventional photon therapy is that when you do it in such a way, these are again the curves, you still get all of this dose that's delivered to the head and neck region, the throat, the chest, the pelvis, the abdomen. And we know that that results in more nausea, in more mucositis, in more difficulty in tolerating the treatment. And so that's one of the limitations of being able to do CSI with conventional photon-based techniques. But with protons, as you can see on the left-hand side, all of that is spared, including a lot more of the bone marrow, thereby allowing patients to actually complete this treatment, because we know that you need to treat the entire axis. And so this is, again, at least in New York, and I know in many other institutions, a very, very strong and growing indication for the use of protons as it pertains to spine oncology patients. So with that, hopefully, I appreciate you guys and your attention. Gives you a little bit of an introduction as to, what proton therapy is, and in what sort of situations, specifically as it pertains to spine oncology, we think about using protons.
Great, wonderful talk there, Dr. Chopra and Dr. Palmer. We have about 15 minutes left, and we want to kind of spend this last bit of time really kind of talking about various pressure points, both clinically but also programmatically, that we can derive some knowledge as to how best to implement this in our own clinical practice. I can kind of kick it off with just maybe some more programmatic questions, but and this can be for both, Dr. Chopra and Dr. Palmer, but, how do you build this collaborative relationship with surgeons? And then, what are some pressure points you guys are handling? And then in general, how do you guys handle fragmentation of care? Obviously, patients get surgery at one institution and then come to you for the radiation follow-up. How do you kind of piece that together and then maybe even integrate that with your local surgeons? Maybe we can start with Dr. Chopra and then bounce to Dr. Palmer.
Yeah, sure. And I think so I'll say it is something that we have to navigate at the Proton Center specifically, in part because we are despite us being part of a consortium that's led by MSK, Montefiore, and Mount Sinai, the 3 sort of major institutions in the New York City area, we are still a referral center for anybody within the region, being the only Proton Center from Boston down into the southern Jersey, Pennsylvania area. You can imagine we get patients from all over the place. So it is something that we do have to very much navigate. And I think the way to do so is really very close lines of communication as it pertains to email, to phone, and a lot of education to referring providers around sort of considerations that we have as radiation oncologists about why it's important for them to be aware of that. Josh, I think we'll talk a little bit about, like, for instance, carbon peak, and he did emphasize that thinking through obviously the appropriate type of hardware that surgeons are using is very, very critical when thinking about what radiotherapy modality you're using. But also similarly, as I alluded to here, thinking through what are the right subset of patients for whom to consider SBRT for, consider conventional radiotherapy for, consider protons for, is really an effort of continuous education and sort of establishing, that line and respective communication. So I don't know if that answers the question, but I think it's just constant and close communication with a lot of sort of education around what it is that we do, regardless of how nuanced that is, such that surgeons can, and we can sort of have this appreciation of what sometimes we're doing as radicals.
Yeah, and I agree with that. I think those are the critical parts as you're building a program. Those are things that we need. I can speak as sort of in my experience. The critical parts are that communication component, but not necessarily just between those two, like a referring spine in person and sort of the radiation oncologist, but also within the group, because our group is on the larger side, and then I think it just depends on the variation sizes of your group that you're working in. But we have sort of now 3 up to 4 surgeons doing spine oncology, as well as now 7 different people doing spine oncology from a CNS side. And so there's variations in how we do things. So I think also just keeping up communication in a organized fashion within each other's groups, so that people get similar recommendations, that we get, strategically integrate different technologies into the system, like carbon peak or radiosurgery. These all kind of require buy-in from the team, because you don't want some folks offering a certain therapy and others another. And so you want the whole group to be aligned. And I think part of that is communication, tumor boards, discussions programmatically. And then similarly, we also get referrals from outside centers or states that are near us. And I think those individuals, it's critical that they're just kept in the loop. I think part of the communication, it's important to get into the system, but also feeding back on things that can improve or things that are changing, because some surgeons in our area don't know necessarily that they can have the option for carbon fiber, because we end up getting patients that we exchange or do or treat differently based on the surgical technique. So I think that sort of nuanced discussion with outside surgeons is an important component. So I think it's within your own group trying to get that kind of clear consensus, so that we're communicating effectively across everyone, and then getting that sort of interaction with the surgeons both in your system and outside, so that way you can create the program where you're sort of treating every patient sort of in a similar fashion, thinking about it through that stepwise process.
As a follow-up to that, I think this really does deal, I think, more so with Proton. But when it comes to the idea of the surgeon planning their surgery, and let's say they don't have someone that they can kind of readily call, but they're dealing with a primary spine tumor where they may not be able to get a gross total or an en-bloc resection. In your opinions, would you say like that's the person where, or for that patient, we should really upfront be using carbon fiber, peak carbon fiber types of constructs to make sure that we don't take off the table the kind of the proton beam as an option? Is that something that people should consider just doing up front if they know they have, limited disease, chondrosarcoma or chordoma or something like that they're treating?
Well, Josh, you can go first. Yeah.
Yeah, I was just going to say that from my perspective, yes, I do think that if you're in a setting where you think that adjuvant radiation, especially protons, will be necessary, I think carbon peak has a lot of potential benefits from an imaging standpoint, treatment planning, the ability to use IMPT properly. I think are all better with the plan in our planning system with carbon, or at least as much carbon as you can get, because I know that there's situations where, based on your surgical and skills and what you know is necessary. There are situations where some combination of titanium or carbon may be necessary. The things that I would be thinking about is areas at risk for disease that you're seeing in surgery. The best thing to do would be around those regions as much carbon as you can get. And then outside of those areas, if it's necessary for surgical construct or you're worried patient's age or some reason that you don't think carbon alone would be strong enough, I think adding titanium to other areas is reasonable, but ideally around the area of interest, we want as much carbon or density that's similar to the normal tissue around it, which gives us more leeway, both with radiosurgery, but also with protons.
Got it. So like hybrid constructs where you're really blending the titanium, the classic titanium with the newer carbon fiber. Makes sense. Yeah.
Yeah, and I'll just add one point to that, which carbon fiber, from my perspective, serves two purposes. One is obviously visualization of the cord, as Josh alluded to. That's important regardless of modality that you're using, whether it's SBRT or protons, metastatic or primary. But when you're thinking about primary tumors, and you are thinking about a patient potentially getting protons for many of the reasons that we alluded to, carbon peak becomes really critical to allow us to achieve the dose that we need to, in part because protons unfortunately cannot travel through titanium without us having losing a lot of hair, that they're not going to go exactly where we expect them to go. And obviously, if we're dose escalating 70, 74 gray, even when we're not dose escalating and we're at 50, 54 gray around the cord, if you get hotspots or you get perturbations, I mean, you could put that patient at risk. And so we do ask our surgeons, and again, this is just that close communication because the first case may not be a carbon case. They may be putting titanium in as sort of as their standard practice. But then the second case, third case, fourth case is when you hope for them to kind of change practice patterns, is for them to understand that if they're going to think about protons, carbon peak, at least in the area of interest where the highest risk is, should absolutely be very, very strongly considered. And there are times we'll have to not be able to treat patients with protons because they have titanium or too much titanium where we want to put the highest amounts of dose, but you hope that that's the last time that happens in that relationship because then you sort of have that line of communication.
Got it.
Chris, maybe just one small kind of more logistical question for both of you guys. If as a surgeon, if you feel strong for a patient to get protons, obviously not all centers have access to proton therapy. Kind of what is the best way to kind of either establish that communication or kind of maybe preemptively think about how do I get that patient the best, radiation type care post-operatively?
Yes. Do you want to?
Yeah, I think
You're also a referral center for your region.
I think as a referral center for the region, I think the critical things are just trying to get access to the people you want to start emailing or communicating with the team members there. So somehow getting in contact with someone that works there. And then they can usually get you the right person. So like I've had people in the past send referrals in, and then we usually, if it's not someone who already reaches out to us, we usually will reach out directly to them. Because like, for instance, we've had Cleveland Clinic patients or Pittsburgh patients at places around us that if there's a surgeon sending us a case, we typically will then reach out to them directly to then create that communication line so they have our numbers and know who to call and how to reach us and both for that case and future cases. But if you're trying to create that line of communication for someone or for a center that may be a little further out, but still within the catchment area of several, close enough that the patient's willing to drive to, I think at least reaching out to their center and saying, hey, I'd like to start discussing referrals. They'll usually give you the contact of the docs that treat that site. So that way you have their personal contacts, emails, hopefully cell phone numbers, so you can more directly discuss patients and their care.
Yeah, most proton centers obviously do have active websites, and I would just encourage referring the surgeons to go onto that website and either call directly or just put in a query or ask your team obviously to do so and say, I want to talk to the person who treats specifically CNS tumors, treats intracranial, treats spine. And I think that's a good way to kind of establish a relationship. Most radiation oncologists, I would hope, are very eager to establish that line of communication, especially when they work at, proton centers. So they'd be more than happy to kind of have those conversations.
And then I want to circle back to a clinical question. This one pops up, I think, for me a lot in my practice. But when it comes to treating recurrent metastases, right? So they've gone through their first round of, SBRT, but then X amount of time later, they now have a recurrence. When do you each think about bringing proton beam radiation as opposed to photon-based radiation into the equation? Is it at the time of, the first recurrent disease? Is it like third time recurrence? Like, how do you guys kind of think about that? 'Cause I always struggle with this is when do you think about bringing in protons?
I was afraid you were going to ask this question since we're in New York and MSK. So, I think I'll try to speak from the non-New York Proton, non-MSK perspective, which is, so the reason being is we do probably a lot more proton SBRT for recurrent spinal metastases than most proton centers do. That, we'll obviously be publishing our data soon that Chris, your team, Josh, and our team have sort of been putting out there. I would say it's a function in our mind of, and this is my personal belief, VMAT SBRT still is more conformal than proton SBRT. The reason being is we are limited by the number of beam angles that we use for protons because we don't want to use, at least as it stands right now on August 26th, we don't use proton beams from all different angles around the patient to treat a small metastases because that would defeat the entire point of minimizing the integral dose if you're coming in anteriorly, laterally, et cetera. And so because VMAT still goes all the way around the patient, you still get a little bit better hugging around the areas of the epidermal space and around the cord. And so in that regard, the conformality is still higher with VMAT than it is with protons. In the recurrent setting, why that isn't always a slam dunk for thinking about conventional VMAT is because obviously the tissues around it have already been radiated. And I think that's where you think about the location of the tumor. So when tumors are higher up around the esophagus, that's a scenario where you might take a little bit of a loss around conformality, but in an effort to minimize that reirradiated dose to the esophagus, to the heart, to the lungs. And so we would consider potentially protons there. Whereas down below, the bowels are sort of moving around. There's really not a lot of other sort of anterior structure. You want to take that sort of conformality because it's okay if you sort of give low to moderate amounts of reirradiation dose to the bowels, because that again is more tolerable, it's more mobile. That's kind of a little bit of how at least I sort of personally think about it, but I'd love to hear what sort of Josh thinks. This is very much still an open area of continued evaluation.
Yeah, because I think at least from a what is considered standard now standpoint, doing reirradiation spine lesions with protons is still something that not a lot of institutions are doing routinely. I think because of like Arpit was mentioning, that you can get a reirradiation plan with radiosurgery that can still very effectively and conformally retreat these patients with good control, with durable control for another several years. And so a lot of us would just probably, at least for the first recurrence, still, unless there's good clinical data that comes out with you guys and others that potentially it's superior, we would still consider reirradiation therapy with radiosurgery as an alternate, a good standard option. I think where I would start thinking about doing a proton reirradiation with a radiosurgery technique would be for those situations where maybe there is a little bit of room on an OAR and it's already received exceedingly large doses that I think potentially proton planning could spare better. So like these are situations for, at least for us, if we did a comparison of a radiosurgery and a proton plan and found that protons does actually provide a significant dosimetric benefit on a nearby but potentially not a budded surface, then we'd probably switch to a reirradiation with radiosurgery type plan. Both for skull base areas and for like mobile spine areas. And I think right now we typically don't have as large of a volume of those situations where it's like a second or a third or a fourth recurrence or multiple high dose treatments followed by a recurrence that a patient still has a good prognosis in those situations where we target that. But I do think that's a very good and open area that where does proton reirradiation fit, I think is still an important question, whether that's upfront or with a salvage later.
Well, sorry to put you guys on the hot seat with a controversial question, but I think honestly it's thank you guys both so much for the time you've given today, for the really amazing talks, and for the massive amount of information that you've really distilled with some great slides and some great talking points around it. With that, I'll conclude today's session, and I'll tell everyone to look forward to our next session, which will be on primary spine tumors, which I think will dovetail nicely kind of from this one to that one. So thanks everybody for joining, and we'll see you next time.
Thank you.